طيب السلام عليكم جميعا ومساء الخير thank you all for joining us today. This is an effort between three organizations and three associations. Mainly, the idea was by the Association of Sudanese Universities, led by Professor Ali Sayed. He was so worried about how the dengue fever is spreading. So he had one for the universities, and then we said, why don't we have two more? One of them will be for health providers, and thank you all for joining us tonight. And we're going to do one in public for the public, inshallah, next week. So today we're going to discuss the dengue fever, the challenges and opportunities, and how you can help the patients. Shortly, we'll have Dr. Khalid to introduce our wonderful speakers who are experts in the field. The three organizations are the Association of Sudanese University. We have the Association of Sudanese Professors in Qatar, which is the ASBaq that you see in my screen. I'm Dr. Amal Khidir. I'm a pediatrician, and I am the academic secretary of this association. The third association is the Sudanese doctors in Qatar, represented by Dr. Khalid Ahmed. And thank you, Dr. Khalid, for organizing this webinar. He's going to shortly introduce himself and introduce our speakers. I'm going to drop you the link to the Association of Sudanese Universities in the chat. A quick housekeeping before Dr. Khalid to take over to introduce our speaker and moderate the session. We disabled the mute, so we have the Q&A active. So if you have any questions, put it in the Q&A. You will see it in the bottom of your screen. The raise hand, although you raise hand, unfortunately, we can unmute you at this moment. So enjoy the session. And Dr. Khalid, the floor is yours. And thank you to our speakers again. Thank you. And all our participants.
Assalamu alaikum warahmatullah. Thank you very much, Dr. Amal, for the introduction, and thank you for all the efforts and the initiative in making this happen. Thank you, our esteemed speakers. We have our speakers, Dr. Muntasir Usman. He is the director of the epidemics in Sudan under the Ministry of Health, and he's the director of emergencies under the Federal Ministry of Health in Sudan. We have also the second speaker is Dr. Nada Fadl. She is an infectious disease consultant professor of medicine at the University of Medicine in Nebraska University. She had finished she graduated from the University of Khartoum, and then she pursued her career in the United States, where she finished her residency. Then she moved to doing the fellowship in infectious diseases, and currently she's at the University of Medicine at Nebraska College, UNMC. Thank you very much, our esteemed speakers. I think we'll be starting with Dr. Muntasir. He can introduce himself further, and the floor is yours, or the stage is yours, Dr. Muntasir.
طيب شكرا جزيلا دكتور خالد. وأنا سعيد إنه أكون معاكم. شاكر. Thanks a lot to Sudanese Doctor Association in Qatar, and also Association of Sudanese Professors in Qatar, and the Association of Sudanese Universities. I will start speaking about the public health, dengue fever in general in Sudan and globally, and inshallah Prof. Nada will continue. I wish my screen now, is it sharing?
Yes, we can see it.
Okay, and my voice is clear. طيب
Yes, thank you.
Yes.
Thank you. طيب I will start with backgrounds about the dengue fever. All of us know that it is a vector-borne viral disease caused by four serotypes of four serotypes of dengue virus: dengue 1, dengue 2, dengue 3, dengue 4. All the serotypes, they are in the same flavivirus genus, but they are different in their infectiousness, and no one give any immunity to others, although we have lifelong immunity for that we have been infected. It is also coming from the flavivirus viridae. Now it is also flavivirus family that include yellow fever, Zika, Japanese encephalitis, and others, West Nile fever. The dengue fever is found in tropical and subtropical climate. We know that the first confirmation was in 1943 in Japan. Before that, it has been recorded and reported from 16th century, all in Asian. The reports came from Asian, African, also American. More than 100 countries, almost 183 reported countries, around 77 reported zero case, but the remaining, they are reporting cases. The estimation of the incidence of the cases between 100 to 400 million annually. This gave us also the estimation of the population at risk around 3.5, almost 50% of the population worldwide, they are at risk of getting the disease. And unfortunately, there is a significant increase in the reporting cases worldwide annually, almost 30-fold increase during the last 50 years, and particularly during 2024, that we'll see later in the presentation. Most of the dengue infection is asymptomatic, as you know, around 75%. The calculation that we knows before, 50, if we have 50,000, we'll have from them 50 with hemorrhagic manifestation and around 5 to 10 with dengue shock or severe dengue. That means around 50 with severe dengue. Occasionally, dengue can progress to severe disease, as mentioned, shock, severe bleeding, and organ involvement. Infection with one serotype give us long life immunity against the specific serotype with short-term immunity to the others. Subsequent infection with a different type increase the risk of severe complication. The severity came, unfortunately, with the if we have circulation of more than one serotype in the area, and this can explain the situation in Kassala and to some extent Red Sea during this year and previous years. Dengue virus is transmitted to human through the bite of infected female mosquito. The mosquito is Aedes, mainly Aedes aegypti, and we have in the recent years also the causative agent also Aedes albopictus, especially in its name is tiger mosquito, has been seen in Europe also. After feeding on infected person, and the virus replicate in mosquito midgut before disseminating the secondary tissue. And it will take around 8 to 12 days to be infectious and transmit the virus to another human. And then, unfortunately, for her life, the vector will be infectious. Factors associated with the spread of this disease globally, the changing distribution of the vector, Aedes aegypti and Aedes albopictus mosquitoes, especially in previous dengue navy countries. Albopictus also it's like the very cold areas, and we know that it is a household vector that unfortunately it is indoor living and it bites also during the daytime. These are all challenging for the control measures that we'll see later. The consequence of El Nino also, climate change and El Nino also leading increase in temperature and high rainfall and humidity, and this observed in some countries, including Sudan. Fragile health system in the midst of COVID pandemic also affected the preventive measures, surveillance part, and vector surveillance, ecological surveillance, human surveillance, and also the preventive and control measures. Political and financial instability in countries facing complex humanitarian crisis and high population movement, for example, also Sudan, unfortunately. The urbanization, I think the urbanization, because this is a tropical disease, the vector itself find in the tropical and subtropical areas, and also in the urban and semi-urban areas. Spread of international travel plays uh, a role, especially passive movement of the vector or the movement of the infectious patients from area to area, from areas that has the disease to areas that free of the disease. And unfortunately, with the availability of the vector ADs in this area, so we are observing now significant spread of the disease all through the globe, including Africa, Asia, America. There are reports of cases in Europe since 2023. Ways of water storage, this is another factor. And I think this is the factor that spread the disease here in Sudan due to the shortage in the water supply, that most of the community in their households, they have tanks, especially in what we observe in North Kordofan, in Khartoum state, in Jazeera state, and also in Port Sudan and Kassala states. نحن لما يكون عندنا التنوكة ومفتوحة unfortunately قابلة لأنها the ADs it's prefer to hatch and breed في solid base containers including اللي هو التانكس إذا كانت البراميل أو الأزيار. لو عينا للجلوبال overview in general, this is the reports that recently shared it has been shared in August during the regional committee, WHO regional committee in Doha. They mentioned that the reported cases around 12 million, including around 7,800 deaths from 166 countries in the globe. This is, if we compare it to the previous reports in 200 or in 2000, we'll find that almost this has been duplicated 3 times. A total of 183 countries reported, and 77 reported 0 cases during 2024. If we check the severe cases, we will find them around 37,000 in compared to the all reported diseases. That will give us the burden of severity, although we have to consider the underreporting, in particularly from the developing countries. Just accept the Americas, because they have the monitor system, they have surveillance system and lab-based surveillance system that is in place using rapid test, using others modalities, real-time PCR, serology. So they are detecting the cases, almost most of the cases. But if we compare it to the Africa and Eastern Mediterranean, we'll find that they are reporting few cases. The Eastern Mediterranean, Sudan is part of the Eastern Mediterranean region reported countries. Dengue number of cases is annual base. We will find that this gives us the clue that there is a real sharp increase, significant sharp increase in the cases of the dengue fever during the last years, including 2023, that it's almost more than 6 million reported cases. This is, sorry, if we check the map, this was in 2012, the global dengue risk, we'll find that Sudan is part of that. Unfortunately, for this time, when we will go to the reporting, we'll find us that most of the states are reporting in the country. So this showed us the risk of the areas, including the areas that or the countries that in the yellow fever zone, because there are Aedes aegypti, and other areas that reported dengue fever outside the yellow fever zone. I will go further. This is a high global risk of the dengue fever, and the grading that dengue fever now is grade 3. That means highly pathogenic of emergency for health emergency event that for international concern, and it requires more efforts to contain, although the observed from the globe that although there are significant increase in the reporting of the cases, but the control measures is beyond the capacity to contain most of these outbreaks. We'll go to the Sudan situation. If we look to this picture, a map of the country, we'll find only northern state that didn't report cases. Unfortunately, Sinnar reported cases, local cases in 2023, and now also in 2024 they are reporting suspected cases for confirmation. Still, due to the conflict situation, now we are in a good shape to have the samples from Sinnar for confirmation in the National Public Health Lab. In addition to that, also Blue Nile in 2006, they reported cases of dengue fever through WHO in the areas, SPLA areas at that time, that was coordinated and by the SPLA Southern Sudan at that time. So with this picture, unfortunately, we are just waiting for Northern State to report local transmission dengue fever. The diseases in the country started to be reported through one of the studies in 1986 had been conducted by CDC in Red Sea. In some samples, they found circulation of dengue fever in the Red Sea state. Uh, the first reported outbreak of dengue fever was in 2003 in Port Sudan, and from that we found that the disease start to spread or to be reported in Kassala, uh, South Kordofan during the yellow fever outbreak at that time, mixed with the yellow fever and other viral hemorrhagic fevers, and then also to Darfur areas after the yellow fever outbreak that reported from, unfortunately, from the five states at that time, 2012. After 2012, immediately we started to receive reports from Darfur areas. In North Kordofan, they have a report in 2012 for some cases, sporadic cases, but it started to increase during 2019 up to 2022. That they faced in Al Ubaid in particular high density of population of vector, and also high incidence of reported infectious cases and admissions. Then the reports also started from Khartoum 2022 and Jazeera 2023. Uh, this map will update share it with you later, inshallah. The current situation in this 2024 showing that up to date 8,000 reported cases, including 16 deaths with case fatality rate less than 1%, 0.2%. These reports came from 8 states and 34 in 34 localities. The most reported areas including Kassala and Khartoum states. This also shows the trend here shows that there is a declining in the reported cases due to the winter season, end of the rainy season, and the beginning of winter in the country. This is examples of some states reported: Kassala, Khartoum, and Gadaref state. In Gadaref state, some of the cases, newly reported cases, refer to the Jazeera state cases, and most of it they are suspected case of dengue fever imported from Jazeera state due to the recent movement of East Jazeera population as IDPs to Gadaref, Kassala, and River Nile. When we check the pillars of the and components of the preparedness and response, we will find the governance and leadership, that including also the regulations. Part of the key areas for vector control to include the community and also to enforce that, to have measurements that reduce the burden of the disease through, in some areas, drying of the containers one day of the week, and regular cleaning of the areas with follow-up from and monitor from the health cadre at locality and state level and federal level. Unfortunately, we are lacking these activities for several years due to the insufficient availability of health cadre at locality level. Plan for early preparedness and response. This is one of the steps for the preparedness and containment of the disease, starting from the dry season to prepare for the rainy season that will include the outbreaks. Unfortunately, we have two rainy seasons in the country, one in the Red Sea and the others that started from November, and the others started from April up to September annually. The coordination part playing role, surveillance and EON, definitely surveillance, that including the public health surveillance, vector surveillance, ecological surveillance, laboratory capacity for the confirmation, including PCR, serology, sequencing, and RDTs, patient care, vector surveillance and control, new dengue vaccines that now it is part of uh, the preventive and control measures. Still, it is on the trial, although it is pre-qualified by WHO. Dedicated trained human resources, secure financial resources, logistic and essential supplies, in addition to the risk communication and community engagement as a tool. I will, in this minutes, I will go through some of the experience of the countries in addition to national strategies that they are used, starting from Indonesia. I will find that they have 6 strategies, including enhancing effective, safe, and continuous vector management, patient care, strengthening comprehensive dengue surveillance, response outbreaks, increasing sustainability of community engagement, and strengthening government commitment, policy and programs, and improvement also of the assessment, invention, and innovation researches, basis evidence for policy and program management. Singapore also, these two countries, they are reporting endemic, they are high endemic countries of dengue fever. Also Singapore, this is the objectives, including surveillance for case and population, virus, vector, and ecology. Sustained prevention, outbreak management, public communication, and advocacy. And this is the strategy of Sultanate Oman. They also have strategy, including manuals for integrated vector management. They have malaria, but for nowadays it is free. And also they reported dengue fever outbreaks. The vector surveillance, global arbovirus initiatives, including monitor the risk and anticipate, reduce epidemic risk, strengthen vector control, prevent and prepare for pandemic, enhance innovation and new approaches. This is all the pillars for global arbovirus initiative, and build coalition of partners. We have here in the country, in Sudan, the Volunteer for Vector Control Project. This is initiated by Prof. Fatih Malik for the country, and we acknowledge the work. Now, this will be supported to play a role in vector control. We'll start from Kassala and will be evaluated and then expanded to the, this will be depend on volunteers from every household, to include a volunteer, young, old, male, female, everyone, to be included and taking the responsibility and lead in the vector control activities. In particularly, they will start from Kassala, and we think this will play a role in the vector control activities. Other vector control interventions, as you know, for the malaria, we know the Anopheles insecticide treated bed nets. This is now the strategy in addition to indoor residual spray. For the dengue, larviciding and larva source management, space spray, ULV and thermal fogging, and community engagement. Selected intervention under WHO. This will have the vector control advisor group. They consider to take the chemosensory interference, spatial relevance, vector traps, ADs population replacement, and ADs population suppression. This through some of the technical tactics that now they are using in some countries, including Singapore, Brazil, and also Thailand and other countries, and Indonesia. For the some of these, they are including also in Saudi Arabia. We'll go through it. New technology for surveillance and control of arbovirus. This is some part, including risk stratification, characterization of the priority areas, popular mobilization, intra-domiciliary residual spray, mosquito disseminated, Wolbachia, and sterile insect technique, and vaccines. Wolbachia, they are using bacteria that to infect the adult male or adult female, so that we will not find any replication from the mosquito for hatching. The infected mosquitoes can be all or male and female or male only. This is one of the strategies that has been used even by Saudi Arabia last year, and we are searching and observing with them to see the outcome from that. Sterile insect technique. This is another technique also for irradiation. Induce sterility for the male, and then will not find also the same that the number of the vector themselves will be reduced. This is another technique. There is also the old technique that use a vector trap, target ADs itself, and this they are putting it within the households, and they are collecting from it the ADs. Spatial repellent, this is also another technique using chemicals. These are some of the techniques that they are using nowadays to reduce the burden of the dengue and other arbovirus diseases. Although there is a significant increase globally in this dengue fever outbreaks and reporting countries. The challenge for the country we are facing, including security, IDVs, as you know, the movement of the population from area to area, the circulation of more than one serotype, in particular in Kassala and in Port Sudan. Unfortunately, in Kassala, we observed one serotype 1, 3, and 4. That mean, and we know that the severity will increase when we have more than one serotype. The underfunding, difficulty in reporting, insufficient vector surveillance, laziness of community engagement. Some of them they don't know, and some of the others they know, but they do not apply for the dryness and for the regular cleaning of the containers. Difficulties in distribution of supplies, delay in global contribution, also playing a role, or insufficient the contribution globally. Way forward, including comprehensive response with multi-sectoral approach, definitely to include other sectors in this prevention and control measures, increase the local and global contribution and commitment. These other sectors, including the education, higher education, university schools, and others, in addition to the institutes, to play its role in prevention and control of this disease, increase local and global contribution, focus on initiative for engagement of the communities like that one volunteer for vector control that will be established in the country, inshallah, during the coming weeks. Focus on IDPs and high-risk areas, empower and reactivate the local health system. These are the part of the reference that I used. Thank you very much. I'm ready to receive any questions. Over to you, Dr.
Thank you very much, Dr. Muntasir, for the comprehensive presentation, highlighting the importance of the disease and the impact that it has on the health system and on the public population. I would like, before I introduce our second speaker, I would like to welcome Professor Ali Said Omar, who is the Secretary General of the Association of Sudanese University, which had the lead on this topic of dengue fever when, like a couple of 3 weeks ago, they organized for a presentation by Dr. Hamad. And we took the idea from them, and we decided, as Dr. Amal has mentioned earlier, to make it into 2 more sessions. Just another point before I introduce Prof. Nada. It was earlier mentioned by Dr. Amal that all the questions are to be dropped into the question and answer. That raising hands and writing the question in the chat we might miss them, but please put them on the question and answer. If you have any query, put it on the question and answer, and we'll get them at the end of the talk. So without further delay, I would like to introduce Prof. Nada Fadl again, who's a professor of medicine in the University of Nebraska Medical Center. She will talk to us about the clinical manifestations and management of dengue fever. So welcome, Dr. Nada.
طيب السلام عليكم وشكرا لكم كثير. كل الشكر ل Association of Sudanese Professors in Qatar, Sudanese Doctor Association of Qatar, and Association of Sudanese Universities على الدعوة دي. I'm really glad to be with you today. I'll be speaking about dengue virus infection, clinical manifestations, and management. As you know, Dr. Muntasir has done a great job covering the epidemiological aspect of dengue. I'll be referring to them a little bit here and there لأنه في حاجات في الepidemiology that's really highly related to clinical manifestation and also the management of dengue. So without further ado, let's start. I don't have any conflicts or disclosures, but I wanted to point out that many of these slides are courtesy of WHO Health Emergencies. And the WHO EMRO office has done a great job delivering training for our Sudanese healthcare professionals. And I'm using some of the slides that they have used for training because they do reflect the algorithms and the management pathways that we use in Sudan. So just some general principles of dengue virus infection that we all need to know. And these are really helpful so that they can orient us to the discussion later. That Dr. Muntasir already mentioned, this is estimated that maybe 390 million people have dengue virus infection globally each year, and 96 million are clinically apparent with some suggestion or symptoms that suggest that they might have dengue virus. Now, the clinical apparent infection, though, is more common among adults. Children usually have minimal symptomatic or sometimes completely asymptomatic infection. So that's something to keep in mind because children can get reinfected and have severe disease, but we might not know that they had previous infection. And like Dr. Muntasir mentioned, the primary dengue virus infection is the first wild type infection, And then the secondary infection is the second wild type infection, which is caused by different dengue virus. So it's important to keep this language in mind because we would refer to this very often. We say primary and secondary. So primary is the first wild type infection that somebody got. It could be by serotype 1, for example. And then the secondary infection is caused by a different serotype because the primary infection gives you immunity from that specific serotype that you had the primary infection with, but it does not give you immunity from other serotypes. There is some cross-reactivity, but that immunity does not last for a long period of time. It lasts probably less than 2 years, generally estimated. And because of that, the secondary infection that is separated by more than 18 months usually represents the highest risk for resulting in severe clinical outcomes. So if somebody gets infected again by a different serotype, and that infection is after 18 months, let's say 2 years, then that's the highest risk for having severe dengue and severe clinical outcomes, because at that point, they do not have any immunity for the other serotypes. And they do have actually some memory of the prior infection that could exacerbate the clinical presentation. And we'll talk about that in a minute when we talk about the immunology of this. Now, the incubation of the dengue fever usually, or dengue infection, I'll be using dengue infection and dengue fever interchangeably because the classification has changed, but we still remember the old terminology sometimes, and we use that very often. So the incubation period is about 3 to 14 days, usually. Usually on the shorter side, though. Symptoms typically develop between 4 and 7 days after the bite of infected mosquito. So usually very quickly after the bite, people start developing symptoms, and this is a little different than malaria, for example. Now, patients with suspected dengue should be assessed very carefully and directed to the appropriate care setting, because if we miss the diagnosis, then the person is at very high risk for having severe clinical outcomes. That's why it's important to have clinical suspicion and also triage them appropriately. And that early recognition and progression to severe disease and patients at increased risk for severe disease is really essential, because we need to start initiation of aggressive therapy very quickly. Unfortunately, there is no treatment, so usually supportive care is all we have, but that can be life-saving if it's initiated very quickly. So this is just a little diagram from UpToDate about the immunopathology of dengue fever, and it's really important to understand these basic concepts so that we know why secondary infection is more severe. So this is divided into 4 stages or areas of infection. So viral replication, non-specific immune response, T lymphocyte response, and antibody. So these are the different specific immune responses that happen. Point 0 is the infection with the virus. And then the x-axis shows the days after infection. So usually there is an infection. After that, there is replication of the virus that happens inside the cells. It's not really known which cells exactly dengue virus infects first, but we know that it does infect several types of cells after it starts replicating and disseminating. So that happens initially, that it replicates inside the cells, and then it replicates inside the regional lymph nodes. And from there, start disseminating across the body. And during that dissemination, that's when the symptoms happen. And that's a stage of viremia. And right at the end of that stage of viremia, that's a period at highest risk for dengue hemorrhagic fever, or severe dengue, as we call it right now. So this is the viral replication side of it. When you look at the non-specific immune response, there is very high release of interferons and NK cell activity during this disseminated infection, and towards the end of it, that's when the interferons and cytokines peak, and it's thought that this is why we have the critical phase of infection towards the end of the dissemination. Now, in terms of T lymphocyte response and antibody response, those differ between the primary and secondary infection. So the primary infection is in red here, the secondary infection is in this green color. Notice that in the primary infection, the T lymphocyte response happens later, happens during day 6 or so. And it doesn't really peak very high. So you have some T lymphocyte response, and then it goes down around the recovery time, but it does not completely disappear. And that's why when people have secondary infection, those memory T cells get reactivated very early on. So instead of day 6 in primary infection, these get activated during day 3 or so. And they peak extremely highly. And that with T lymphocyte activity, obviously there is a high release of interferons and other cytokines, especially inflammatory cytokines. And it's thought maybe this has to do with why people with secondary infection have a higher risk of developing severe dengue. Same with antibody response. Antibody response, especially IgM, obviously starts earlier, IgG starts later. And in primary infection, that doesn't really start until around day 8 or 10 of the infection, but the antibody response is not that high. Now, notice in secondary infection, there is maybe some slight antibody response at baseline because somebody who got infected by a different serotype, they still have some antibodies circulating that protects them from that specific serotype. And then when they get infected by a different serotype, which we call secondary infection, there is really high rise of IgG response in the patient with secondary infection. And maybe this is what leads to complement activation and immune complex response. And that's probably what causes this severe dengue in patients who have secondary infection. So these two phenomena, the T lymphocyte and the antibody response, that's what I thought to be causing severe dengue in patients who have secondary infection. Now, when we look at the laboratory findings as well as the antibody response and the phases of dengue, so the phases of dengue are here in the bottom. So you have the febrile phase, which is usually day 0 to 7. The critical phase, which usually happens anytime between day 4 till day 6 or 7. And it lasts only 1 to 2 days. So the febrile phase is long. It can be up to 7 days. The critical phase lasts only for 2 days. And this is where people have the risk of shock and hemorrhage. And then after that follows the recovery phase, which can go up to day 10 or longer, depending on the immune status of the patient. So initially in the febrile phase, there is a high temperature. The white cell count, platelets, and hematocrits are usually in the normal level. And the virus, this is where dissemination happens. So the viral RNA and NSI antigen are usually very high during this phase. Now, antibodies, obviously, especially in primary infections, have not yet developed. So they develop very slowly. IgM peaks a little quicker, and IgG takes a while to recover. Now, for secondary infection showed in the dotted line here, you can see that the IgG was already there. It wasn't 0 at the beginning, and it peaks pretty quickly. And in the critical phase, it reaches a very high level. And that's, again, why probably secondary infection has a higher risk of complications. Now, when we get to the critical phase, in addition to the rise of IgG, you see that the laboratory markers start changing, right? So the hematocrit increases significantly, and this is due to hemoconcentration. Temperature can drop, and it can become normal, or sometimes even somebody can become hypothermic. The white cell count actually goes down, and sometimes it goes down before the platelets. So that could be an early warning sign that somebody is developing leukopenia. They might develop that before they develop thrombocytopenia. So it's important to pay attention to the white cell count. And then by the time they develop thrombocytopenia, that's when they're in the middle of the critical phase. Now, in the recovery phase, obviously, things normalize because the antibodies now form and they're able to eradicate the virus. So the IgG response rises, the IgM response rises in primary infection. So these are the 3 stages and how they correlate with antibody response and also the fever and laboratory findings. So in terms of the clinical course of dengue, so things to keep in mind is that dengue is a very systematic and dynamic disease, meaning that symptomatic patients can appear to have very mild symptoms and have a very mild acute febrile illness, almost like a viral respiratory illness. They can have headache, myalgia by day 2, and then by day 4, 2 days later, they can have persistent vomiting and other warning signs for severe disease. So they can change very rapidly. So it's important to monitor these patients very closely. Understanding the clinical course and recognizing these warning signs is so paramount because if we provide the correct treatment, we can prevent complications and deaths. And after that incubation period, the illness usually just begins very abruptly. Somebody could be normal and then next day they have severe fever, and they have this manifestations of illness. And these are the 3 stages we talked about. So mosquito bite, and then the incubation period can last up to 7 days. And then patients start having viremia. They have first the febrile phase, the critical phase, and the recovery phase. And we'll be talking about these persistently. So keep in mind, febrile phase, 0 to 7 days. Critical phase usually lasts 2 days. And then the recovery phase lasts about 3 to 5 days. So the whole illness duration is about 10 to 14 days usually. Okay, so the febrile phase of dengue, usually this is characterized by the duration being about 0 to 7 days. Usually people have biphasic fever, so meaning that they have a high fever, they get better, and then they have fever again. The defervescence usually is when a warning sign starts happening. So it's very important to pay attention to when somebody's fever is coming down. That's a stage where the IgM is high in the primary infection, IgG is high in secondary infection, and that's a stage where they're at very high risk for developing severe dengue. So it's important to pay attention to their laboratory markers and clinical markers at the time when they defervesce. And this is a stage of viremia. After that, they move on to the critical phase. During the critical phase, they're usually not viremic because the severity is not driven so much by the virus, although there are some studies showing the higher the viral level in the initial phase, the more likely they will develop severe dengue, but this is not being proven to be consistent. Nonetheless, in the critical phase, the mediation of that severity is usually due to immune activation, and then the recovery phase, which lasts about 3 to 5 days, as we mentioned earlier. Now, the critical phase, what happens during that time? Usually it begins around the time of defervescence, as I mentioned, but it might begin a little earlier, as early as the 3rd day after fever onset. It really kind of depends on the patient and their prior history and their immune status. So patients can still be febrile. So don't say, oh, he has fever, that means he's not in the critical phase. No, absolutely not, because patients can be still febrile and they can enter the critical phase, but normally they're not. And this is a period when those who develop severe disease will become critically ill. Now, most dengue patients actually improve during this phase and do not develop severe disease. So again, not every patient will develop severe disease. As Dr. Montasser said, the majority actually will not have severe disease, but that percentage of patients who develop severe disease, this is around the time when those signs start showing. And it can be identified by one of these things. Either they have rapid decline in the platelet count with a rise at the hematocrit. So at the same time, while the hematocrit is going up, they have heme concentration, their platelets are coming down. And usually that disconnect is not normally seen in other diseases, because if somebody's heme concentrated, their hemoglobin goes up, their platelet go up as well as the white blood cell count. The patient may develop leukopenia maybe 24 hours before the platelet starts dropping. So it's important to recognize that if the patient developing leukopenia, that's something concerning and you need to pay closer attention to them. And they have other warning signs. So for example, clinical fluid accumulation, they can have ascites, they have pleural effusion, they can have liver enlargement. So it's really important to examine these patients really well and closely. They can manifest with severe abdominal pain, almost mimicking acute abdomen. They can have persistent vomiting, 3 vomiting episodes in 24 hours, and they can have mucosal bleeding, so bleeding from their gums, nasal bleeding. Those are usually also warning signs. And they can appear very restless, or they can appear very lethargic. So any changes in their activity or function also raises the alarm that the patient may have warning signs. So the WHO changed the classification from dengue hemorrhagic fever, and the dengue septic shock syndrome to now calling it dengue with warning signs, dengue without warning signs, and severe dengue. So again, a lot of the infections are asymptomatic. Some patients have symptomatic infection, and that's divided into 3: undifferentiated fever, dengue, and that's divided into no warning signs and warning signs, and then severe dengue, which is severe plasma leakage, severe bleeding, and organs severely impaired as manifested by organ dysfunction. So these are the 3 stages of those who have symptomatic dengue. So dengue without warning signs, dengue with warning signs, and severe dengue. So we kind of talked about this already, but I'm going to go into it because it's really important to triage patients importantly into the right category, because based on that, then you will manage them in the hospital or outpatient or even in the ICU for patients with severe dengue. So how do you suspect somebody has dengue? Even if they don't have warning signs, if they have lived or traveled to areas with dengue, which now in Sudan, unfortunately, that's pretty much everywhere, and they have had mosquito bites in those areas, which is, again, unfortunately now because of the situation, that happens everywhere. And usually they have 2 and 7 days duration, and they have nausea, vomiting, rash, headache, and it's characterized by retroorbital pain. Patients will say that I have severe pain behind my eyes, and that's usually one of those characteristic signs of dengue. It doesn't mean it's very specific to dengue, but if somebody says that, then that raises the alarm. They have severe myalgias and severe arthralgias, usually not arthritis. They don't have fluid in their joint, but they have severe arthralgias. And they also can have petechiae in their skin and leukopenia. Now, any child residing in a dengue transmission area with acute fever, they might not have these symptoms, but you have to also suspect it in children, because we said children might not have those symptoms, but you have to also suspect it highly. They don't have to have all these symptoms. Now, dengue with warning signs, it could be any case with dengue. So the prior symptoms that we just talked about. In addition to that, they can have intense abdominal pain or tenderness, persistent vomiting, fluid accumulation such as ascites or pleural effusion or pericardial effusion, mucosal bleeding, lethargy or restlessness, postural hypertension. So when you examine them, they drop their blood pressure when you have them stand up, liver enlargement, and progressive increase in hematocrit. So when people start having these signs, that's now dengue with warning signs, and they need to be hospitalized. Severe dengue can have all of the prior manifestations in addition to shock or respiratory distress due to severe plasma leakage. We'll talk about that later. And the shock could be evidenced by weak or undetectable pulse, cold extremity, increased capillary fill, or pulse pressure less than 20 millimeter mercury, which this indicates that this patient has hypotension. Now, severe bleeding can be evaluated by attending physicians. So patient has hematemesis, melena, metrorrhagia, or central nervous system bleeding, which is usually a very severe complication. But if the attending physician or the medical staff decides that this is severe bleeding, that satisfies the criteria, because sometimes it's very difficult to scan these patients and actually identify that they're bleeding internally. Now, organ compromise can be due to manifest as liver compromise, which can be due to the hypotension that patients experience. So AST and ALT are usually above 1,000. They can have central nervous system compromise, which manifests as altered status. They can have kidney compromise. They can have myocarditis or heart failure. So any signs of any organ compromise will qualify as one of the criteria for severe dengue. So again, shock, severe bleeding, and organ compromise. Those are the 3 things that define that this patient has severe dengue. So diagnosis of dengue usually depends on the clinical approach. I know somebody asked earlier if we have laboratory testing, and I'll let Dr. Muntasir comment on that later. But the important thing to keep in mind is that the clinical approach and clinical diagnosis is actually pretty good in evaluating patients with dengue. And it should be suspected if there is an outbreak of dengue. If somebody is presenting with symptoms and signs suggestive of dengue, that's usually very diagnostic. There is also the tourniquet test, and I'll show that in a minute. So if they have those clinical signs, along with the epidemiological exposure, which in our case usually is the time of the year or the outbreaks happening, that by itself can be conditional diagnosis of dengue. Now, the provisional diagnosis usually is pretty good, as I mentioned, because then if you follow that patient, if you need to wait for laboratory testing, sometimes it takes time. It's not readily available unless you have RDT readily handy, which is not always the case. And in our case, if you have patient who's suspected and you have RDTs, you still probably want to involve the National Public Health Lab, especially if it's the beginning of the outbreak, so that they know that this is a suspected case. Now, the positive predictive value, as I mentioned, of the clinical criteria is very high. especially if the illness is meeting dengue hemorrhagic fever or severe dengue criteria. Now, the problem, though, in our region is that dengue, malaria, other illnesses can look very similar. So you have to have a very high risk of suspicion. So many times we manage patients as if they have malaria, but they might, in fact, actually have dengue because the epidemiology is pretty similar between the two, unfortunately. So it makes it hard to differentiate. Now, if available, as I mentioned, laboratory confirmation is warranted and would be very helpful because that will help us with surveillance. So this is the tourniquet sign. So basically it's due to microvascular fragility. So this is basically performing blood pressure, inflating the blood pressure cuff on the arm to midway between systolic and diastolic pressure. So after you check the blood pressure, then you go somewhere in the midway between those. So if it was 120/80, for example, you inflate to about 100, and then you leave that cuff for some time, and then you start releasing it at least after 1 minute, and then you examine the skin. So if the patient develops petechiae, that's usually a sign of microvascular fragility and or thrombocytopenia. So that's usually a marker for dengue. Now, this test is pretty sensitive, actually, but unfortunately, it's not very specific. It can happen in other types of diseases. I remember I had a case of typhus during my fellowship, and somebody performed the tourniquet test and it was positive, and they were very determined that this patient has dengue. But when we asked the patient more questions, she had exposure to wild animals and rats. So we eventually actually diagnosed her with typhus and gave her doxycycline, and she got much better. So don't get hooked on the fact that this is always dengue, but the tourniquet sign is very readily available. It's in the floor in the ward, so you can perform that and see. Now, in terms of diagnostic tests, as we mentioned, there is different types of assay. The serology, IgM and IgG, is usually not extremely helpful. I mean, it can be positive if somebody had prior infection. You could still find IgG positivity. If somebody has primary infection, IgM usually rises, but in those cases, it's not really going to be. Usually patients don't have severe infections, so it's not going to be very helpful. What's helpful, though, if you can detect the PCR or if you can detect the antigen, the NS1 antigen, as we mentioned earlier, through some type of ICT diagnosis. So this is another diagram that shows the same thing. So viremia, you can isolate the virus pretty early, a few days after diagnosis. At the same time, you can isolate antigens because antigen and virus particles usually go hand in hand. And then the IgG and IgM rise kind of a little later, but IgM rises obviously first, and then IgG rises second. Now, the other important thing to assess for these patients is their hemodynamic status. So you have to assess their blood pressure, you have to assess their capillary refill, you have to assess that if they have a low pulse pressure difference, and what are the other symptoms that you can look for in these patients. Their level of consciousness can be very helpful. Skin temperature, the color of the skin, the moisture of their mucous membranes, heart rate, and respiratory rate, urine output, all of these can be very helpful in assessing hemodynamic status. So we have a lot of tools at the bedside to be able to assess the patient and figure out if they have any warning signs that can tell you that this patient may develop severe dengue. So in patients with dengue, if the patient develops hypotension, the systolic blood pressure decreases very rapidly, and they can get into a state of irreversible shock very quickly. And it's important to kind of catch them before that state of irreversible shock, because by definition, irreversible is very hard to reverse, and they can go into organ dysfunction, and they can unfortunately die if we don't catch them very early. So this is basically where the diagram for shock. So it's critical to identify patients when they're in compensated shock before they get to decompensated shock. And early signs could be narrowing of pulse pressure. As I mentioned earlier, less than 20. The diastolic blood pressure starts rising and systolic blood pressure starts dropping. That's usually a very concerning sign. Delayed capillary refill more than 2 seconds, and tachycardia in absence of fever. Now, if they have fever and they're tachycardic, it could be because of the fever, but if they don't have fever and they're tachycardic, that's a warning sign that there might be developing shock. identifying those early signs is very important because we can catch them early on while they have compensated shock. Because if we get to the stage of decompensated shock, the blood pressure drops very quickly, and it's really hard to resuscitate them in spite of aggressive blood pressure, aggressive volume resuscitation, etc. So this early stage is extremely important, and is why it's important to monitor patients closely if they're in the hospital. Now, obviously, nowadays, with the situation of shortage of medical staff and supplies, etc., this becomes very difficult. So that's why it's important to recruit as many healthcare providers to help during these times of outbreak. Now, the other stage that can happen is plasma leakage, which this is very severe. And if the patient gets into this stage, unfortunately, their prognosis is very poor. And this is diagnosed by having ascites or pleural effusion, either by examination or imaging. They can have hypoalbuminemia or proteinemia by checking serum albumin to total protein level. Hemoconcentration, as I mentioned earlier, increasing hematocrit compared to patient baseline. If you don't have a baseline for that patient because they didn't check the hematocrit when they were first diagnosed, you could use the population average as your baseline. And if the increase is above 20%, that usually means this patient has hemoconcentration. Now, if a patient drops their hematocrit by 20% with stable vital signs, that can happen after volume replacement, because remember, the hematocrit was not high because the patient is making more red blood cells. The hematocrit was high because the patient was hemoconcentrated. So if you give them fluid, you should expect that the hematocrit can drop actually quite a bit, even to the point where maybe they're slightly anemic, but not severely anemic. So this is the clinical pathway for dengue patient classification, which is extremely important because if we follow the right pathway and diagnose and triage patients accordingly, then the chances that the patient will receive the appropriate volume of fluid, they will receive the appropriate resuscitation is much better. So it's important that we group them into the right classification. The WHO has 3 classifications or 3 grouping, which is group A, group B, and group C, and we'll talk about these in a minute. So basically, the algorithm is actually pretty simple. Now, anyone with fever, this was adopted in 2023. So this is a recent algorithm. Maybe there is a recent adaptation after that, but I haven't really seen it. But anyone with fever more than 38 degrees Celsius with 2 or more of the following symptoms during the febrile phase: headache, pain behind the eyes, joint pain, muscle pain, back pain, loss of appetite or rash, very general and non-specific symptoms. Then if that's the case, then you have to suspect dengue in the appropriate areas. You can call the rapid response team, or you proceed with evaluating this patient for admission. Now, if the patient doesn't have anything, then you have to investigate what else is causing the patient to have a fever, and then you examine and triage them accordingly. Now, if the patient has these symptoms, you should suspect this could be dengue, it could be malaria. You have to actually think about both, because if it's a malaria case and you miss treating that, the patient can deteriorate. Also remember that malaria and dengue can happen simultaneously. Patients can have co-infection with both, even though the mosquito vector is different, but in cases of outbreaks and flooding and climate change, both mosquitoes unfortunately can occur at the same time, so co-infection can happen. So it's recommended that you evaluate clinically, and if testing is available, you test for both by blood film, ICT, or RDT, whichever is available. Now, if you confirm one or the other, if it's malaria, you treat it accordingly. If it's dengue, obviously, then you go to the severity screening algorithm, which is shown here. To decide if this is dengue, then we need to classify it accordingly. Now, if you don't have testing for dengue, that's fine. You rule out malaria, and then you evaluate clinically for dengue, and you triage it as if it's dengue, especially if there is an outbreak. So the severity screening divides patients to 3 groups, and very similar to the criteria we talked about earlier, the warning signs and the severe dengue. So this is what you use. So basically, dengue without warning sign, this is group A. Dengue with warning signs, this is group B, and severe dengue is group C. The difference here is that group A, without warning signs, can be treated at home. Group B, these are patients who should be admitted to the hospital because they can progress very rapidly to severe dengue, And group C, obviously, they need to be admitted and maybe to the intensive care unit if available. So group A patients, usually they live in an area of dengue. They traveled to an area that has dengue outbreak in the past 14 days. They have nausea, rash, headache, myalgia, like we spoke earlier, petechiae, maybe leukopenia. Group B patient, those are the people who have the warning signs that we talked about. And group C patients, those are patients who have shock, severe bleeding, and severe organ compromise. So these are the three classifications you should keep in mind because those are the ones that dictate management. So in terms of group A patients, again, these are patients without warning signs. These patients can be managed at home, but they should be counseled very well before they're sent home, because sometimes what we do is we send patients home because we're overwhelmed, the hospital is over capacity, but we don't provide them with the appropriate counseling before they go home, and then they deteriorate very rapidly. So you should probably follow these patients daily. We don't usually have the ability to follow them daily, but if there is a primary health center nearby, or they have a physician, primary care physician, they should be seen every day for at least those initial days to make sure they get out of the critical phase of illness. Assessing hemodynamic status, making sure they're not entering the critical phase, checking the blood count, if possible, to make sure they don't have leukopenia or thrombocytopenia or hemoconcentration, and also ask the patient about the warning signs that we talked about earlier. Importantly, in this phase, do not give NSAIDs, do not give non-steroidals to these patients, do not give aspirin, do not give ibuprofen, any non-steroidals for these patients, because that can cause thrombocytopenia and can accelerate the development of hemorrhage. Do not give corticosteroids. It hasn't been shown to be beneficial. It may even cause some degree of immunosuppression to make it a little worse. Antibiotics have not been shown to be beneficial, obviously, because this is not a bacterial infection. So it's very important that we're good stewards of antibiotics. So it's recommended not to give those to patients unless you highly suspect a secondary bacterial infection. This is actually a sheet that can be given to patients to go home with. As you can see, this is وزارة الصحة الاتحادية, WHO. It tells the patients how to care for themselves at home, how to watch for symptoms, to rest, watch for symptoms of dehydration, how to prevent dehydration, how to control their temperature. So this is very important. Make sure the patient can read and write too, because that's another mistake that we do. Sometimes we give patients sheets when they cannot read and write. This is from Pan American Hospital Health Association organization in collaboration with the WHO. This is another sheet that we can tell patients, or we can translate it and give it to people, what to watch for. They should watch for drop in the temperature, intense abdominal pain, drowsiness, dizziness, bleeding from gums, restlessness, or persistent vomiting. If any of these symptoms happen, those are the warning symptoms, and they should present to the hospital immediately. So that's for category A. Again, treat at home, but counsel them extensively on what to watch for. For group B, which is dengue with warning signs, these patients need to be hospitalized. We have to think about other diseases, rolling out malaria. You put them in rest in the hospital, you control their pain and temperature with paracetamol or acetaminophen. Obviously, you don't give them any non-steroidals as well. You give them IV fluids, usually preferably with Ringer lactate or normal saline, but it's given gradually because you want to avoid hypervolemia in these patients or volume overload. So you give them 5 to 7 ml per kg for 12 hours. There is an algorithm actually from the Ministry of Health that has all these details. So don't feel like you have to remember all of this. I put some links at the end so you can go and find these as well. If the patient starts drinking well, you don't really need to continue IV fluid because IV fluid is in shortage as well. So you want to prioritize those for patients who are not drinking. But if the patient starts drinking well and the urine output improves, you can actually stop intravenous hydration. Now, patients with group C, this is where patients need to be managed in the intensive care or as if they're in the ICU. So these are patients who have hemorrhage, plasma leakage, and shock. And in this case, the patient needs to be treated for severe dehydration very carefully and promptly. You give them, again, either normal saline, Ringer lactate. It's not recommended to use dextran because it can cause worsening of hemorrhagic complications. But if you have certain signs you need colloidal fluids, then you may want to use albumin for those patients. Now, the volume is a little higher, obviously, than patients in group B. So 2 ml per kg within 15 minutes as a single dose, and then you reduce it to 10 ml per kg per hour afterwards. You evaluate their hematocrit and you evaluate their platelets. And you discontinue again IV fluids once they start drinking. Remember, this critical phase and severe, it usually lasts 1 to 2 days. So it's not like you have to treat these patients for several days. Usually it's 1 to 2 days. If you get them out of this stage, then they go into recovery phase. If the patient develops severe anemia, which can happen sometimes because patient can have hemorrhage and internal bleeding, in those patients, you can give them blood transfusion, but it's not recommended to give them platelet transfusion because platelets have not been shown to improve outcomes in these patients. But blood transfusion, RBCs, is fine, but you also have to be very careful because you have to monitor for volume overload in these patients. So this is a very nice diagram that shows you what compensated shock. This is a stage, again, where you can catch the patient and you can prevent their decompensation. So kind of just keep this in mind. It's also available in the algorithm that I mentioned. Again, as I mentioned earlier, using isotonic crystalloid solutions, such as Ringer's or normal saline, is okay and preferred. Colloidal solution, if the blood pressure has dropped very massively and you have to restore it urgently, in those cases, you may use colloidal solutions. Now, patients with dengue, as we mentioned earlier, can deteriorate very quickly. They can have significant plasma leakage. They can go into very severe shock. So you have to resuscitate them very urgently, but also keep in mind they don't need fluids for a very long time. Most of them, they need it for 24 to 48 hours. And after that, if resuscitated at the appropriate stage in a compensated phase, they can survive. And if not, if you continue the fluid, they can go into heart failure and volume overload. And that actually usually indicates poor prognosis. We did talk a little bit about blood transfusion. It's recommended that you give it when hematocrit is less than 40% in children and females and less than 45% in adults, so in adult males. So the threshold for males is a little higher. It's also recommended if you don't have access to colloidal solutions that you can give it. Again, platelets are not recommended, have not been shown to be effective. Blood transfusion has to be given with care because you want to prevent fluid overload. So the rate is usually 5 to 10 of fresh packed red blood cells or 10 to 20 of fresh blood, whole blood. You want to give supplementary oxygen if possible while they're getting blood transfusion. That usually tends to improve their breathing and oxygenation. You should consider repeating the blood transfusion if needed, if their hematocrit does not respond, or if they have continued bleeding, but there is no value for continuing the blood transfusion if their hematocrit has responded, even if they have some slight bleeding going on, especially upper GI bleeding, because you can still have the signs that they're bleeding, having black stool, but they might not be actually bleeding freshly. So you have to watch for that very carefully because you don't want to get them into volume overload or heart failure because these patients also have high risk of myocarditis. So keep that in mind. So again, just a summary, group A can be treated at home. You give them anticipatory guidance prior to sending them home. Give them the patient handout. You follow them daily. You do serial CBCs. And you identify warning signs early and counsel them about them. Group B, admit them to the hospital. You monitor the hemodynamic status very closely. You look for signs of early compensated shock, and you can use the hematocrit and platelets to determine if they need interventions. If the hematocrit starts going up, white count starts going down, that's usually early sign before the platelets start dropping. And use IV fluids judiciously in these patients and encourage oral rehydration in them. And if there is metabolic acidosis or electrolyte abnormality, correct those accordingly. In group C, those are the patients that need resuscitation, basically. So you use crystalloids preferably, but if they need colloids for refractory shock, you can use those. And you monitor them for occult bleeding, but do not give them platelet transfusion. So some additional manifestations to keep in mind that patients can develop liver failure, usually has been described after resuscitation from profound shock. So after they get their blood pressure increases, next day you check and their enzymes, liver enzymes are high or they have developed jaundice. This is usually thought to be due to prolonged hyperperfusion, leading to liver shock, and their enzymes usually are in the 1,000 in these patients. Neurologic complications have been described, and these could be encephalopathy or seizure. And unfortunately, some patients have developed permanent neurological damage. Cardiovascular manifestations such as myocardial impairment, arrhythmias, and occasionally fulminant myocarditis, leading to shock or heart failure, have been described. Acute kidney injury, again, usually the manifestation of shock, hemodynamic shock, or sometimes could be due to rhabdomyolysis. Some patients develop glomerulonephritis due to immune complex disposition. Retinal vasculitis, very rare manifestation, but has been described. So if the patient starts complaining of eye pain or vision changes, watch out for that. Another complication, which is very rare but very important to pay attention to, is secondary hemophagocytic lymphohistiocytosis, or HLH. I usually say HLH, I don't use the long name. This is a fatal hyperinflammatory condition that can happen due to dengue and so many other infectious agents. So again, watch out for this. The signs, unfortunately, can be very similar to severe dengue, but it can be differentiated. There's certain criteria that you can use to watch for that. Bacterial co-infection with or following dengue has been described, but not all patients have bacterial co-infection, so there is really no need to give antibiotics unless the patient has signs suggesting bacterial infection. So if their white count is going up instead of going down, or their fever is prolonged, or they have focal signs of infection, those are the patients. Again, malaria co-infection can happen. It can be hard to distinguish from dengue. It can be fatal if not treated, because it's been thought that malaria happening with dengue tends to be more severe than malaria alone, which kind of makes sense. But something to keep in mind, if the fever is lasting very long, then in that case, you should probably examine the peripheral smear and make sure this is not malaria. Now, in terms of differential diagnosis, unfortunately, a lot of the symptoms and signs of dengue, especially early on, are very nonspecific. So you have to keep in mind a lot of other things. So other viral hemorrhagic fevers, which are in the region right now and may unfortunately cross to Sudan in the future, those you have to keep in mind. So things like Ebola, Marburg virus, Congo hemorrhagic fever, chikungunya, which was also an epidemic in parts of Eastern Sudan, typhoid fever, leptospirosis, parvovirus B19, especially in children. Acute HIV infection can also manifest very similar to dengue, and that can be missed very easily. Viral hepatitis, especially with the elevated LFTs, because it can cause the high elevation with acute hepatitis. Rickettsial infection, I mentioned a case of typhus earlier, but African rickettsiosis and other rickettsial infection can sometimes present similar to dengue. Even influenza and COVID-19 can be similar to dengue, but the differentiation here is that patients have respiratory symptoms. So in summary, dengue is a dynamic disease impacted by climate and population changes. Therefore, clinical suspicion is paramount. You can't say we never had dengue in this region, therefore this is not dengue. In the absence of lab testing, clinical diagnosis has a very high positive predictive value. Ensure that patients are assigned a clinical pathway that's correct for them. And early identification and management of severe dengue is very important. Supportive care is really the mainstay. Blood transfusion can be helpful, but platelet transfusion and steroids have not been shown to be effective. Look for complications and co-infections and treat those accordingly. These are some of the references. I'll leave the slides with the team so they can share them later. And thank you again very much for inviting me.
Well, thank you very much, Prof. Nada, for this comprehensive talk about. Thank you very much, Prof. Nada, for the comprehensive talk. I think we can have a few questions on the ground. Let's start with Dr. Muntasir. We have the first question is, how is the diagnosis of dengue fever confirmed in Sudan? and that was also mentioned by Dr. Nada that she will leave it for you to answer it. So, any comments, Dr. Muntasir?
Thank you, Dr. Khalid. Thank you, Dr. Nada. Regarding the question of Nidal, diagnosis confirmation, how we have, do we have? Yes, we have rapid test distributed almost to all these secure states, in addition to some of the hard to reach states, including Northern Darfur. And part of this possibility or probability of the cases coming from the rapid test, dengue rapid test. We have also real-time PCR in the National Public Health Lab in Port Sudan for the confirmation. The cases, some of the cases confirmed. We do not want to confirm all the cases in the affected area, but we have to have this EP link with some of the cases. And there are rapid tests. I think with the mix of the rapid tests and ICT, we can have some solution regarding the confusion between both of them, and is in particular these days with high density of ADs and also high density of anopheles in the same area. So we have to consider that to use RDTs. Dr. Anada may elaborate more in this. For the consequence, now it is ready in Port Sudan. They will start, and it will be also replicated in Kassala state. The capacity in Kassala and Gadaref state are there. However, for River Nile state, maybe we need more improvement, but for the confirmation of dengue fever. They have the capacities, they have PCR machines, but the reagents are not available with them yet. And the second, the coming work will be for improvement of the lab tests in these areas. For the E1s that from Dr. Hamad, I can go further, Dr.
Yes, please. Yes.
The early warning system that we are using is not that you may mention for it regarding the early warning that have been used by other countries for ecology, for others also for prediction for some of the outbreaks, for prediction for sometimes earthquake and others like a Nino. We have only part of the syndromic EWAR early warning system that it is complementing to the indicator-based surveillance we are using in the hard-to-reach areas. So the early warning system that you mentioned, it is only used during the beginning of the rainy season and used by our colleague in civil defense that they have the system, but not with a wide scope that to include also some indicators for Sudan for the public health. For the vector control responsibility during the outbreaks, it is a responsibility of Ministry of Health if they have no capacity at the state level or local level. But for the routine work, it is a local health system. It is a locality responsibility. They used to have even Mal al-Namus and public health officer. They have الملاحظين برضه ملاحظين الصحة observers. دير كلهم موجودين كان available. Unfortunately, we lost them. We lost part of the good work with those people within the areas that is high density of vectors. And as mentioned by Prof. Al-Fatih, I mentioned also during my presentation, Prof. Al-Fatih vector for volunteer for vector control. I mentioned it in one of the initiation that and acknowledge your initiation for that, and we're expecting it to play a key role in dengue fever vector control activity in addition to the others home vectors. طيب like the Stephen Sai for the malaria. For the strengthening of the national public health, I think for Hanan, I gave this answer. Can be also fit with Hanan question about strengthening for the lab, National Public Health Lab and other labs in safe areas. For the surveillance, we have the surveillance. It is in place, although there are underreporting. We consider that underreporting, but the reporting of increase of malaria cases sometimes is evidence of increasing of dengue fever in areas that reported dengue fever outbreak or localities reported dengue fever outbreak. We consider that, and the teams working to use both modalities, including the rapid test, as I mentioned, and rapid test for viral hemorrhagic fever and ICT for malaria. Over to you, Dr. Khalid.
Thank you very much. There is one comment from Ilham from Gadarif that in Gadarif they diagnose it by RDTs for IgG, IgM, and NS1, and then they confirm it by the aid of case studies. That's just a comment sharing their experience in Gadarif. Thank you very much, Ms. Ilham, for sharing your experience. Dr. Muntasir, before we move to Prof. Nada, we have a question that the dengue is there in Sudan since 2000. That actually the attendees mentioning, sorry, I might have missed this in your talk, but we haven't heard about dengue in early years. Then since about the year 2000 or so, we suddenly start hearing about it. So where did it come from?
As I mentioned, the recorded outbreak, first outbreak of dengue fever was in 2003 in Sudan. It was in 2003 in Port Sudan. This is our first outbreak. But for serology, there is a paper study found in 1986 types of dengue fever in Port Sudan in the Red Sea state. So there is a possibility of having the dengue in Red Sea before 2003. But for sure the spread of the disease started from 2003 because after only 1 year we observed the outbreak in Kassala 2004, and then in South Kordofan. For Kassala and Port Sudan, all the colleagues knows the link between Kassala and Port Sudan, especially during the summer season in Port Sudan, that the people move to Kassala. So the link between Kassala and Port Sudan showed that the increase of the case or the spread of the disease started from 2003 in the country, and unfortunately now we have almost 17 out of 18 states they have endemicity of dengue fever or vector available in their area. Out to you, sir. Over to
Yeah.
you, Doctor.
Yeah, thank you very much, Dr. Muntasir. Prof. Nada, we have a few questions, starting with actually some of the questions are from Dr. Al-Fatih Al-Malik. The first question is like in context like Sudan, the diagnosis of dengue constitutes a real dilemma because of coexisting diseases such as malaria, as you've mentioned in your presentation, and the non-availability of rapid tests. So how do you approach such patients? in these situations? I think you've touched based on that. If you can just elaborate more on it. Thank you.
Yeah, I mean, it's really difficult. I mean, there's some differences, but there is a lot of similarities as well. There's difference, obviously, in transmission and prevention, which mosquitoes, but those can coexist at the same time due to the rainy season. There are some slight differences in presentation. Usually, malaria fever is prolonged compared to dengue, but again, you don't want to wait till it's a little too long to diagnose dengue. So there is a challenge sometimes, but I think even if in absence in rapid diagnostic tests, which we heard that in most safe states, those are available, but remember there is so many states, unfortunately, right now where access is not as open and easy. So for those clinicians, they really have to rely heavily on clinical diagnosis. And if peripheral smear is available, those skills, unfortunately, are waning away because most people now are relying on RDTs. But the peripheral smear can be extremely helpful in diagnosing malaria as well. So that can be used. Now, if you diagnose malaria, that does not rule out dengue because co-infection can exist. So if patients start having increased hematocrit, that could be a very differentiating factor because in malaria, obviously, you should not have increased hematocrit because of the hemolysis. So that could be a sign that this patient might not have malaria, they might have dengue. Leukopenia is also uncommon in malaria, but it's pretty common in dengue and could be an easy early warning sign to use. I did mention the tourniquet test. That's another differentiating test that you can use to check to see if this patient may have dengue and thrombocytopenia and vascular leakage, etc. Things like pleural effusion, ascites, those are also uncommon in malaria, so you could use that to diagnose dengue. So there are some differentiating factors, but they're not really that different, to be honest. So you have to have a very high clinical suspicion. But if you rely on lab tests, I would highly recommend peripheral smear and hematocrit tests, which are very easy and accessible even in non-safe states.
Yeah, thank you very much for the answer. So another question is, I noticed that most of the suspected dengue cases are treated at home with IV fluids and injectable analgesics, and that might be explained by the fact that patients might not have access to the health care for follow-up. But the problem that they might be missed. So it looks like a conservative approach from the participants' points of view. So if you can comment on that, please.
Yeah, I mean, I agree with Prof. Al-Fatih, and I think for most of us who lived in Sudan and trained in Sudan, we know that many patients rely on home management. You might have a nurse or a doctor in the neighborhood, and they administer fluids and administer antipyretics and antiemetics and all kinds of medications at home. I'm old enough where we used to use quinine for treatment of malaria, and many times we have our neighbor, administering that, which is extremely dangerous, obviously. But many patients, either because of lack of access, and there is also issues of, I have to say, mistrust in the healthcare system. People feel like if they go to the hospital, they have a higher risk of complications and death, which in some places it might be true, in some places it might be misconception. But a lot of people rely, unfortunately, on home management, which is pretty dangerous in cases of dengue. We should be discouraging that. But it's really hard to discourage it if there is no access in the hospital because we have a team now working in different states in Sudan. And when there was an outbreak, they sent me pictures from the hospital where patients were literally في الحوش بتاع المستشفى ومعلق لهم الدريبات في الشجر وبتاع. It's really hard to tell patients, no, you absolutely have to be at home when there is extremely limited access and limited personnel at the hospital. So I think we could just do what we can. Like Dr. Muntasir said earlier, volunteers can be very helpful for prevention, but trained volunteers, if they're very well trained, can be extremely helpful in situations of outbreak like this and situations of emergency.
Thank you very much for the answer. So one more question is about the use of steroids. That you said they have no role or might even cause some relative deterioration of the case. So the question is about that. Initially during COVID, we thought it's contraindicated, but later they were proved to be beneficial. So is that the case in dengue fever or? or not, and any
Yeah, that's a
explanations?
great question. That's a very good question. And actually, the difference, unfortunately, between dengue and COVID is that with COVID, we have tons of data that developed extremely rapidly because the disease was a pandemic. So that drove a lot of funding and a lot of people to study it, not like dengue, because there is no funding and there is not really a lot of benefit to pharmaceuticals from studying dengue because there's no treatment. So we don't have as much data, but what we know is that a lot of observational data and maybe some retrospective data suggest that steroids can exacerbate bleeding, especially gastrointestinal bleeding and ulcers. And that's why it's not recommended. I think it depends on the source. I think the CDC says contraindicated and WHO says not recommended. I might be mixing those in my head, but I do practice in the US where we occasionally see dengues in travelers. And in our algorithms, we do not administer steroids and consider them contraindicated because of those reasons. And the studies that have been done, the small ones, did not show any benefit. Now, if we have larger randomized control trials, we may be able to see something different, especially if we're able to study the immunopathology and the effect of steroids on that very closely. But right now, unfortunately, we don't have that data.
Well, I think that also answers another question that's on the chat about during the critical phase, which is primarily due to immune response to virus. Can we, in this case, use the steroids to stop the cytokine storm? So I think that kind of
Yeah,
the question.
it's not recommended again, even in the critical phase. It's usually just supportive management, and the patient's immunoglobulins start kind of controlling the virus. The good thing about dengue is not like HIV and other viruses that persist in the body for a long time. The immunoglobulins are usually able to produce neutralizing immunity and get rid of the virus. So it's just kind of holding the patient together until that happens in the next few days.
Okay. So we have a few questions, I think, for Dr. Muntasir. How to make the maximum benefits of the community participation in the prevention? And another question is there any vaccine? And I think that question was read also by Prof. Ali Said, that in view of the immune system, is there any vaccine or is it going to be beneficial in Sudan, if any?
We'll start with the vaccine. Dengue vaccine is pre-qualified by WHO, as I mentioned during the presentation. It is for those seropositive, serological positive, or as a case, and between 9 and 45 years old. Still, for us, it is a query. It is better to be discussed internally and also considering and having our colleagues like Prof. Nada and the Sudanese Association, Professor in Qatar and Association Sudanese also for the in the universities to consider if we can use it. But for nowadays, it is not globally used. It is only used in the localized areas. So we are not benefiting of using it. It is better to work in the preventive and control measures. The war situation complicated all these things, including the routine activities and also the response to outbreaks. There are delay in availing the vector control supplies during this year, and unfortunately also the last year. Also the strategy of using the bed nets globe with in the prevention of malaria for Sudan, and not using the vector control activities. This also affect the spread of the density of vectors of malaria and also the Aedes aegypti. This is, I think, for the one of the questions or two of the questions, the community participation, yes. As mentioned, Professor Fatih Malik, now he is working on the volunteer for vector control that will target the every volunteer from every household. This will be covered and monitored also through formal system. This is one of the good initiatives in addition to the regulations and laws that also can be enforced to for the community, in addition to raising the awareness for the community to play a role. This vector is hard to be eradicated or cleaned, although it is weak in its movement, but it will move almost to 100 kilometers per year and can move passively with the transportations. And unfortunately, we have risk factors like containers, like the tanks, open tanks. It is a good area for the Aedes aegypti to go breed and also replicate with possibility of vertical transmission. Other points that has been raised, Blue Nile Institute is it is collaboration between the for Dr. Nabil. It is collaboration between Federal Ministry of Health and Jazeera University, and we know that they have the work in the Aedes aegypti and Anopheles, and also Al-Gaddal, and also for the other institutes like in Khartoum University. Also, we have another institute that they are working in researches for supporting the country. Uh, these areas we know, but for the possibility of having the disease that the imported cases, unfortunately, all the outbreaks that we record it with local transmission, high density of the vector, Aedes aegypti, and also samples from the patients that confirm it is dengue fever, if it is in eastern part of the country or western part of the country. And this is enough to consider that we have a local transmission. It is not beyond the local, although it can come from anywhere in the world. But unfortunately, we can also be the the driven factor for other countries for this Aedes aegypti. Over to you.
Yeah, thank you very much, Dr. Muntasir, for answering the questions. And we have on the chat, Dr. Mohammedani is sharing their experience in Jazeera, where in 2016 they recruited 180 febrile child and 180 febrile adults, and they just did the dengue test using the rapid test and ELISA, and they found that in the children, the 9% were testing positive and 12% were testing positive in adults. So yeah, I think that's not a minor rate that is there. So it highlights the importance of the disease and its impact, I think. We have
Definitely.
a
Thank
question.
you. Dr. Khalid, I would like also to acknowledge Prof. Mohammedani. He is my teacher. I'm graduated from Jazeera University.
Yeah,
So yes, we do acknowledge all the work that have been done by Prof. Mohammedani. Over to you, Adis.
yeah. Well, we have, I think, one question in or sharing the experience in Kasala that Samixone has been used as part of the treatment protocol. So why is it used? I think the question goes to Dr. Muntasir.
You can repeat the question, sorry, brother.
In Kasala, that Samixone, which is ceftriaxone, I think, is used as part of the treatment protocol for dengue. Although Dr. Nada has mentioned it has antibiotics have no role unless we are suspecting that a superadded bacterial infection. So why is it used as part of the treatment protocol there?
It is not included in the protocol even of the malaria unless the consultant, the specialist, consider another co-infection, bacterial infection. And sometimes even we found them, they are using it in cholera outbreak. So this is areas, sometimes decision came from the consultant himself. But for us, it is not including in the protocol, and we insist in using the protocol for.
Yeah, and if I could just add to that, I agree with Dr. Muntasir. It's not included in any protocol anywhere in the world. The dengue that happens in Sudan is not different than the dengue that happens in South America, than the dengue that happens in Asia. So there is no reason for us to treat it differently. We should just follow international guidelines. But it's really important. It's a responsibility of every one of us to be good stewards of antibiotics, because antimicrobial resistance is rising worldwide. In Sudan, we don't have ability to check every culture for resistance. And we have been using antibiotics like ceftriaxone and meropenem very widely for no reason whatsoever, even for cases of COVID-19 and other cases. So it's so important to be good stewards of antibiotics, because we're not going to have many left, unfortunately, in the future to treat any types of bacterial infections. So I would highly, highly discourage that. If it's in a formal protocol, I would highly recommend reaching out to the case management team through Dr. Muntasir and others at the Federal Ministry of Health, and discussing that, because it shouldn't be. And if the case management team is aware of that, they probably will be able to clear it to the state and others that they should not be included.
Thank you very much, Professor, for sharing that. So, are there any more questions? I can't see any.
There was a
Yes.
question about the question was, are you familiar with our work in BNNICD by Professor Nabil Bashir, I think, University of Jazeera, Medical Entomology and Vector Control Department? Marfa, was that answered? Yeah, maybe.
I answered it.
I think it was addressed, yeah.
I told him that it is a collaboration between Federal Ministry of Health and Jazeera University, the institute itself. Yes, we know the area, the work that they are doing. Even during COVID, the confirmation, all the PCRs and samples were tested in Blue Nile Institute before to improve the capacity of the state lab. Yes, over to you.
Yeah. Thank you very much. If we don't have more questions, we just have one announcement before we conclude this webinar. This talk was directed to the healthcare professionals. So we are planning to conduct another webinar that will be held on the 8th of December. That's in 8 days' time, not tomorrow, the Sunday after. And it will be on the same time. You'll be seeing the announcements with the links or QR codes for those who are using the mobiles to join our session next week, inshallah. So, Dr. Amal, if you have any final words.
Yeah, I just want to invite Professor Ali Said if he wants to say any addition, and then any final words from our speakers, any final advice while Prof. Ali is joining us. Muntasir, any final words you want to advise the audience?
Maybe Prof. Ali, he wants to start,
Yeah,
and then
Prof. Ali, go ahead.
Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. First of all, I have to apologize for me coming late to the meeting because I have one enemy, and that is Zoom. You know, Zoom application, I don't like it at all. And I have so many problems with the Zoom. But anyway, Amal is always insisting of having a Zoom application in these meetings. I have one question. I don't, if possible, because there are some people who are immune to malaria. Sudanese are immune to malaria, a different, category. But are there any person who is immune to dengue fever? This is my question. And before they answer, I want actually to thank everybody. And I think such meetings together with the associations, with the, the experts in other Sudanese experts in other uh, countries, they are all welcome, and are all welcome to share our meetings. They are not as lengthy as your meeting, but anyway, it's again on Saturdays, and everybody is actually welcome to attend the meeting. And I think next week we will have the same problem. We will have, I think, 2 meetings at the same time, but anyway, we'll try to arrange for it because of the Amal is always making these problems for us, both associations. Thank you very much indeed, and I'm really, I think I used to say thank you for everybody, but now I think I got a lot of experience from the 2 speakers, and I think we will have the coming session for the public as you have already announced. And I think this will be more beneficial to our Sudanese people in Sudan. Thank you very much indeed. Thank you.
Yeah, thank you very much, Prof. Ali, for your comments. Just to make it easy on you, the next meeting will not be on Saturday, so you'll have one meeting next Saturday. Our next meeting will be on Sunday, inshallah. So I think that will at least minimize the burden on your shoulder, hopefully.
Inshallah.
Yeah, Dr. Muntasir, if you have any final comments.
طيب أول شيء أنا شاكر جدا لكم في جمعية أطباء السودانيين بقطر، نفس الطريقة الجمعية بتاع الأساتذة في الجامعات السودانية والبروفيسورات أيضا في قطر، جامعات قطر. حقيقة نحن مهم جدا نستعين بكل النتوركس اللي عندنا لنقوي البريفنتيف الكنترول ميجرز للدينج فيفر. للأسف أن احنا شايفينها انتشرت بصورة كبيرة جدا. هي يعني حجم المشكلة أكبر من الإمكانيات المتوفرة لنا، وزادتها للأسف زادتها رهقا الحرب الآن في إنه في areas نحن ما بنقدر نوصلها، وهي بقت لنا مصدر لانتشار المرض. للأسف الشديد الخرطوم كان الفصائل بتاعتنا في كرري ومبدة وجزء من الديم والعمارات. الآن حتى سوبا في ريبورتد كيسز، في بحري في ريبورتد كيسز بصورة كبيرة. دي بتأكد إنه نحن الانتشار بتاعنا حيكون عالي جدا، والناس اللي حترجع إذا ما كانت انفكتد في الارياز بتاعتها أو اوتسايد ذا كانتري حتاخد الانفكشن من الخرطوم وحيستمر لنا لفترة طويلة. الكوميونيتي بارتيسيبيشن مهم جدا، الكوميونيتي انجيجمنت مهم، النتوركينج لإيصال المعلومة في إنه المواطن يعمل شنو في قصة يحفظ الموية، يغطي الأزيار، يغطي الخزانات بتحت الموية. دي مهمة جدا في إنه يحافظ على الوقاية، يقي نفسه، يقي أسرته، يقي المجتمع من المشكلة دي. أنا بفتكر إنه نشتغل بصورة كبيرة، نستفيد من النتورك اللي نحن متوفرة لنا. أنتوا بنفس الطريقة عندكم رسائل، رسائل مهمة جدا. الآن أنتوا عندكم ويبينار حتعملوه للبابليك بيكون مفيد جدا. بفتكر بروف علي بالنسبة لشاكر ومقدر برضو ليك في الانيشيشن. بالنسبة لي أنا ببدأ وبعد كده بروف ندى التتيم. بالنسبة للإميونيتي، أي سيروتايب if you got infected منه بيديك for life الإميونيتي. Unfortunately there are four serotypes وهم كأنهم four diseases. زي ما قالت البروف في إنه بتديك temporal immunity، لكن الشيل reported إنه if you got infected with other serotype. والسيركيوليشن بتاع 1 و 3 و 4 الآن في السودان بيخلينا نحن worried about الكومبليكيشن اللي بتجينا للكيسز، لأنه أي سيركيوليشن لأذر disease البوسيبيليتي لأنه يجينا risk of severe dengue diseases is high. شاكر ومقدر لكم مرة ثانية أخ خالد وأخ أخت أمل للأورجنايزيشن، وشاكر ومقدر لكم في الثلاثة جمعيات لاستضافتنا ولنشر الوعي للمواطنين، ونعمل إنه نكون كنا خفيفين على الناس. Over to you دكتور خالد.
أيوه. شكرا دكتور منتصر، شكرا لك كثير على مشاركتك وعلى وقتك يعني مع انك ما في السودان حاليا، لكن كنت حريص انك تحضر معنا، فشكرا لك كثير. دكتورة ندى، بس any final comments؟
Yeah, no, I'll echo Dr. منتصر. شكرا لكم كثير ASU ASPEC وسوداك اختصارات على ال invitation دي. We really appreciate you guys taking the lead in improving awareness and capacity building. This is needed، يعني الناس تكون جاهزة قبل ما الخريف يجي. So we're not surprised every year يعني. Now it's needed more than ever because of the displacement and the mobilization of people. So يعني I'm glad that we're taking the lead, or you're taking the lead in organizing this ahead of time. وإن شاء الله يعني يكون فيه فايدة للناس. I'm happy to answer any questions later. Happy to connect with anyone. وشكرا للحضور كثير برضو على الانجيجمنت والأسئلة المهمة اللي سألوها. شكرا للدكتور منتصر على الانفورميشن عن الحاصل في السودان. This was extremely helpful to everyone، وسعيدة جدا بالاستضافة، وإن شاء الله to connect مرة ثانية.
شكرا جزيلا our speakers. شكرا للحضور على فعلا يعني الانجيجمنت والكويستشنز والكواليتي اوف questions. They really reflect how engaged people were and how attentive they were and attention they were paying to the presentations. We really enjoyed the presentations, so thank you very much. So Dr. Amal, if you can just final comments and conclude the session if you don't mind.
شكرا جزيلا to our presenters دكتورة ندى، دكتور منتصر، وبروف علي للمساندة والمؤازرة. هي الفكرة طبعا جات من عنده طبعا عشان نديه الكريدت كامل. وشكرا لكل حضور. طبعا تسجل اللقاء ده، وإن شاء الله بنحاول يكون available. هيكون غالبا في الفيسبوك بتاع الرابطة بتاعت الأساتذة، وخالد ممكن يحطه في الويب سايت، وبروف علي هيحطه برضه إن شاء الله في الويب سايت أو بطريقة أو بأخرى. تحياتي لكم جميعا وأمسية سعيدة، ونشوفكم الأسبوع الجاي إن شاء الله. تحياتي، شكرا. السلام عليكم.